Thank you for joining us today. Today we have Dr. Thilo Hackert joining us from Hamburg in Germany. Dr. Thilo will be giving a talk about complication risk and management in pancreatic surgery. Thank you, Dr. Hackert, for joining us, and the floor is yours.
Yes, thank you again for the invitation. It's my pleasure to be with you again. It's been quite a long time now, but I think it's always nice to talk to you and to give these online lectures, also to be in Egypt in person, of course. So today the topic is about complication risk and management in pancreatic surgery. And as you all know, pancreatic surgery is kind of a dangerous surgery. So usually what may happen is something like this. You try to get the car out of the water, and then you see the next car is falling in, and in the third part, the third car is coming, and again, the third car is falling in. So this is what we today call failure to rescue. When you have a complication, you somehow realize the complication, but the things that you do in the end not save the patient because you were too late, you did maybe something wrong, or something else was really unlucky, and finally the patient may die due to your pancreatic resection, due to your pancreatic operation. So how should we estimate this, and how should we try to avoid this? The first thing that is extremely important is you cannot manage complications in your pancreatic surgery surgically. What you need is you need some good anesthesiologists, some good ICU. You need a good interventional radiologist who can fix your complications. You need also a good endoscopy. And finally, as the last step, but really the last step, you might consider surgery to fix your complications in the end. But this is really the last step after you have done everything else, and maybe everything else has failed. Now, the risk factors, the markers, and then of course the fistulas and the hemorrhage are the very important complications, which I will address this evening and talk a little bit about that. Now, how to estimate the risk? You all know the pancreas might be dangerous when you have a soft gland, when you have a small duct. And this has been known for a long time, but there has not been really a categorization of this risk. And so some years ago, we tried to establish this categorization, which is really simple. This is 4 levels of risky pancreas anastomosis, which means if you have a really significant difference between the different pancreases and the rate of your fistulas, which is shown here in a very big collective of patients, of 5,000 patients, where this was based on. You see that you can do 4 categories of different pancreas anastomosis, different dangerous pancreas anastomosis. And this is the simple classification, as I said. A type A pancreas is a hard pancreas with a big duct. A soft pancreas, which is intermediate and a size of less than 3 millimeters. This is a kind of a type B pancreas. In C, you have a soft pancreas with a large duct. So this is a little more dangerous. And in the end, the most challenging is, of course, the type D pancreas, which is very soft. You all know these pancreas when you have done a bile duct cancer, when you have done an IPMN. The pancreas that remains is only a healthy pancreas, and usually it has a main pancreatic duct size of 3 millimeters or even less than 3 millimeters. And all of you know that this is the most difficult anastomosis that you can have. And of course, it is also associated with the highest risk of a fistula after the operation, which is up to maybe even 100%. In some of the patients, you might consider even taking out this pancreas instead of taking the risk for a fistula. The other things that are important as a risk factor is a long surgery, when you do a complex operation, when you have a great blood loss and you need a lot of blood transfusion, when you do multivisceral resections, which are of course associated with all of the 2 other factors. And the fourth, but very important thing also is when you don't do this very often, when you do pancreas twice a year, 5 times a year, maybe 8 times a year, then this is also a risk factor for some pancreatic fistula and for a failure of your anastomosis. How can we recognize this? This is really old data, almost 20 years ago. We did this publication from the Heidelberg team, and you see this was 700 patients, and the total incidence of really severe and septic complications was approximately 13%. This means 1 out of 7 patients is at the risk of developing some severe septic complication that you have to fix in some way. And of course, the pancreatic fistula is also present here. And this is one of the most prominent complications that cause also sepsis, and that can also lead to a very difficult postoperative course. And the parameter which you can use to recognize this as early as possible is quite simple. This is the CRP. If you have a very high CRP on 4 days after the operation, and this doesn't come down as it usually should, then you have a predictor of a septic complication afterwards, which means you cannot prevent this complication, but you can address this complication as early as possible. And whenever you see this, that a patient has this type of laboratory values, then you should be really aggressive to look for your complications. And I will come back to that at the end of my talk a little bit later. Now, the pancreatic fistula, of course, is the most severe complication that can happen. This is kind of the Achilles heel of the operation. You all know this old Greek story of the hero in the war who was only vulnerable at this point. And of course, the vulnerable point in your pancreatic operation is the anastomosis in a high-risk pancreas. This classification by the ISGPF by that time has been put out more than 20 years ago, which was very simple to define the pancreatic fistula postoperatively, which says any postoperative drain with on postoperative day 3 with 3 times higher amylase than usually in your serum levels. And this was also stratified for A, B, and C. This is classified here, as I said, already an old classification of the pancreatic fistula. After this was put out, everybody used it and everybody said this was a good classification for the fistula. We tried to evaluate this classification a little bit later and tried to see if it really discriminates between the severity of the fistula and the postoperative course of the patient, A, B, and C. We did this in 400 patients and said, what is the clinical outcome of the patient? What is the differences? And by that time, and this is why I still like to mention this in my talks, interventional percutaneous drainage was classified as a fistula grade C if you really applied this classification very strictly. And when you do this very strictly with an interventional percutaneous drainage, you see that the rate of grade C fistulas is very high. More than 70% in this collective actually had a grade C fistula, but the outcome of interventional drainage versus especially reoperation was different in the end. And you see, only interventional drainage to manage the fistula, you have 0 mortality. Whenever you have a reoperation, you have a mortality of 40%. So in some way, this classification was not really consistent in the end, because especially the grade C was kind of difficult, either interventional drainage, no mortality, so everything was fine, or reoperation in the end, so you have 40% of mortality. So we said by that time we should rearrange this definition of pancreatic fistula, and we proposed this, that only reoperation or mortality from any other cause, from septic organ failure, for example, should be classified as type C, and not the interventional drainage should already be a type C, but this should be included in type B. This was finalized by the ISGPS 10 years ago. This was the update of the original classification. And you see, this has become quite easy. The grade A fistula was taken out because this has no clinical impact at all. Grade B is everything except for reoperation, organ failure, or death. And then only in these patients, you had a grade C pancreatic fistula. And this classification is still valid today. So whenever you report about your results, when you report about your operations, you should apply this 2016 update of the ISGPS. Now, whenever this happens, what should we do? And I think the most important thing is this, again, almost 25-year-old study, but still this is the first really important study to mention how to manage your complications. You have a failure, you have a complication, and then your radiologist is your best friend. Because whenever you do this, this could be approximately 12% of the patients, you can fix most common complications, which means percutaneous drainage, bleeding, and pancreatic fistula, which is mentioned here. These are the most common interventions that the radiologists do for pancreatic surgery and that they can offer to you to help your patients. And when you see this, you see that these things, abscess, PTCD for bile leakage, angiography, all three things that you would usually think you should do a reoperation for that, can be managed by interventional radiology, and the rate of reoperations really dramatically decreases, only 10 to 17, maybe for bleeding a little bit more, requires a reoperation. Usually you can avoid a reoperation and you can save the patient by sending him to your radiology department. This, of course, needs a 24/7 radiology department when every time somebody is in the house who is able to do these things. This is rather easy. An abscess drainage you can put in also with an ultrasound guidance. PTC, PVD is of course something that is more difficult, and this is probably the most difficult thing when you have a bleeding and you need to do an angiography with an embolization without occluding, for example, the hepatic artery, but only occluding the stump of your GDA. That is the most common source for bleeding, especially when you have a pancreatic fistula in the background. Just an example how this works. You see, everybody knows this. You have this collection due to a pancreatic fistula. Radiologist puts in the drain. He checks that the drain is put correctly, and then this fistula is managed and the patient can recover despite he has developed this postoperative fistula. Today, what is very important, I think, is also the endoscopic drainage, which is shown here, especially when you have a fistula after a left resection, because usually you have something like this. You see this is the remnant pancreas, here is your cut margin, and here is your fluid collection, which is very closely related to the stomach wall. Then you do your endoscopic ultrasound, you can put in a needle and you put in your drainage, and you can drain this very easily into the stomach, which is not only convenient for the patient, but which is also a very good drainage, probably even better than a percutaneous drainage. And this is what you should always discuss with your endoscopist, mostly after left resection. Sometimes you can also do this after a Whipple. You have a fistula with a collection, and in many patients you can check if this can be put in a drainage by transgastric or transduodenal. If you have done a pylorus preserving Whipple, also transduodenal. But of course, you need a good anatomy. You need a good position of this fluid collection, and then this is a very suitable method to address this postoperative fistula even after Whipple resections. When should you go in again and do a total pancreatectomy? I think this is very important. As I mentioned, only in very few patients remaining a remnant pancreatectomy is really necessary. And I will show you some data why you should always try to avoid this. If you do a total pancreatectomy in an elective session, you have a 4.5% mortality. If you do this in an emergency setting because of sepsis, because of bleeding of your pancreatic remnant, you again have something like a 40% mortality, which is extremely high and which already shows you that you should in any way try to avoid this. And this is not only in Germany that I showed you in the first slide, but this is also an experience from other countries. This is something from Canada. You see a systematic review about completion pancreatectomy whenever this was done, and mortality all over the world was approximately again 40%. So again, you should try to avoid this whenever possible. I think this is an interesting study from the Netherlands where they have checked the trends of completion pancreatectomy after a Whipple procedure, 8 centers over 13 years in all of the country. And you see that approximately 16% of the patients that were operated by that time, about 4,600 patients, developed a clinically relevant fistula. Relaparotomy rate was 3% for any reason, and the completion pancreatectomy was only done in 0.7%, which already underlines that the Dutch people were very restrictive to take out the pancreas whenever they could avoid this. The trends are also clearly shown here. The number of reoperations for pancreatic fistulas is decreasing dramatically. with probably the increasing of interventional radiology, and the number of remnant pancreatectomies also decreased dramatically during 10 years of this study, increasing the mortality in the beginning, but then finally also decreasing the orange part of the mortality, which says the less completion pancreatectomies you have to do, you can lower your mortality very significantly. Whenever you have to do a reoperation and you have to address a pancreas because of a fistula, you have very different options to manage this. And I think this is shown quite nicely in this review by these pictures, which means you can disconnect the pancreas, only drain it. You can try to close the pancreas. I think this is something that doesn't make sense. I have never seen this. I have never done this. You might do something like this, disconnect your anastomosis, put a drain in the pancreatic duct and try to bridge this gap between the small bowel and the pancreas. You might go for a completion pancreatectomy. You might also redo your anastomosis. From my experience, again, this is also something that doesn't make sense. I have not seen any redo pancreas anastomosis that turned out to be a good solution in the end and that really helped the patient very much. However, you should always be critical when you go into the OR and first check what your pancreas shows you. This is some old picture that I have still from my time in Heidelberg. You see this was a pancreatic anastomosis, small bowel, and the pancreas, you already see what has happened here. This is a necrotic part of the anastomosis of the pancreas. And when you have something like this in the end, after taking it out, you see that this pancreas could have been in the patient. You didn't need to take this out. You only have the problem of the necrosis in the front, but the rest of the pancreas is quite nice. So you could disconnect the pancreas, put a drain in the remnant pancreas, and then put, of course, some spilling drains into the abdomen and save the remnant of the pancreas without doing a big, again, surgical trauma to the patient. However, there are situations that are very different. It could be the same situation as I showed you in the last slide, anastomosis, necrotic beginning of the pancreas. You decide to take it out, and in the end, you find something like this. A complete pancreas is necrotic until the spleen. So this is, of course, a situation where you do need a remnant pancreatectomy because this patient will never recover when you leave this pancreas inside. What are the risk factors for something like these necrosis that I showed you in the last slides? This is a nice robotic Whipple study, again from the Dutch study group, 37 patients, and they did the ICG perfusion measurement of the pancreatic remnant and correlated this with the leakage rate, with the pancreatitis rate, and with the outcome of the patients. And when you see this with a robot, you can do this very easily. You give your ICG and you check the remnant of the pancreas. So you see this pancreas is nicely perfused up till here. All of this is ICG, but you have at the end some of the areas that are not that well. This one is perfect, and this one is already at the time of the operation hypoperfused, which means by tying your sutures, you have done something to the blood flow, and you have already pre-formed some kind of necrosis in the area of your anastomosis here. And when you look at this, you see the hypoperfusion pancreas has a very high rate of a high risk of developing a fistula and maybe even a remnant pancreatitis. If you have a good perfusion, the rate of pancreatic fistula is much lower and the anastomosis heal much better. I think this is not very difficult to understand, but you could check this. And this tells you that necrosis and pancreatitis of the rest of the pancreas that you leave inside is very dangerous during your operation or after the operation. And therefore, you always have to consider this when doing your sutures and when considering the structure of your pancreas, the soft pancreas, the fatty pancreas, all of these things. We tried then to analyze this to define which patient really needs a remnant pancreatectomy. 4,000 Whipple procedures, 3% of remnant pancreatectomies in an emergency setting, always. What is the timing? What are the reasons? And what are the risk factors? And when you see the most prominent risk factor in this collective was distal cholangio, which means only the bile duct is affected by the tumor, but the rest of the pancreas is completely healthy, as I already mentioned in the beginning of my talk. And then this risk is just done by the structure of the gland, by the diameter of the duct. These are the classical type D pancreas with a nearly, maybe not 100, but 70–80% risk of developing a fistula. And what else these patients like to develop is an acute necrotizing pancreatitis of the remnant. And these are, of course, the patients that do worst, that like to get septic, and that also have a very high mortality in the end compared to all of the other types of pancreas anastomosis and compared to all of the other entities like pancreatic cancer and chronic pancreatitis, patients who nearly never develop a pancreatic fistula. How can you recognize this? You can recognize this again, coming back to the beginning of my talk, with the CRP. A patient with a very high CRP and very high amylase levels in the drain is at a high risk of developing severe fistula, a life-threatening fistula, and also a remnant pancreatitis, just like the picture that I showed you, with a completely necrotic and black remnant of the pancreas in the end. So what is the summary of the pancreatic fistula risk and management? You do not really need routine drains. This is something that has been investigated in the past. If you feel more comfortable, you can put a drain, but this does not lower your risk and it does not prevent your fistula. In some cases, you might consider octreotide analogons in these patients. However, this is also something that is not really preventing all types of fistula. But the important thing is you need to recognize your fistula and your complication early. You have a persisting CRP elevation, day 4 after the operation, do a CT scan very early, and then try to manage the pancreatic fistula, as I already mentioned, with radiologist, endoscopist, ICU, antibiotics, whatever is necessary to do this. Open revision, completion pancreatectomy only in case of sepsis, necrosis that you cannot manage in any other way. Of course, in these situations, you have to go in because otherwise your patient will simply die. But you should always try to avoid the situation and manage your fistula and your everything else before this happens. Now, how about the bile leaks? Just very briefly, when you do have a bile leak very early, of course, you always consider a reoperation just because of some technical failure might have happened. Whenever you have 3, 4, 7 days after the operation and your bile leak occurs, don't go to the operation room because you will not do it any better than the first time. But again, you ask your radiologist to put in some percutaneous management, to put in some PT/CD, and this works in most of the patients. You can see something like here. Your radiologist punctures your bile duct, puts in your drain, and he can manage your bile leakage at the hepatico-jejunostomy without a reoperation. Next thing, chyle leaks, something that is increasing at the moment because many centers in the world do more extended and more radical resections. So probably the incidence today is more 16% than 1%. It is definitely rising. If you have a chyle leak that you recognize early after the operation, of course, you should do a fat-free MCT diet. But the important thing is, if this doesn't help, you can consider lymphography and finally also radiation with a rather low dose. However, radiation is also written in brackets, is something that you don't really need very often. Lymphography, you need a little bit more frequently for really persisting chyle leaks that will not heal without doing anything else than only the diet without the fat. This has also been classified by the ISGPS that you see here, the grade A, B, and C again, according to the severity of the clinical management. And this is some outcomes, how to manage this with a lymphography. However, you see, this is not very common, 59 patients over a 10-year period, and they were again managed by the radiologist with lymphographies through the foot or through the nodes in the groin. And the success rate overall is approximately 50%. So this is not a perfect management, but it is at least a try that you should do. And if you have a little bit of luck, 50% of the patients, this will close very early, very quickly. The other ones, you have to consider either radiation, or if this also fails after 4 weeks, 6 weeks, you can consider reoperation, close, for example, something like this, because this again is a chyle leak that will not close spontaneously. Then you, again, in this case, should reconsider a reoperation. Now, the hemorrhage, for the last point that I want to make, you have, again, the definition by the ISGPS, early versus late, localization in the lumen of the bowel or the stomach or in the abdomen, and again, grades A, B, and C. At the moment, this is currently being revised, this classification, because the ISGPS has recognized it is not perfect. It will be probably finished this year, maybe come out next year. I'm not really sure how the process is working right now, but at the moment, this is still the classification that you should use, A, B, C. And you see again a little bit relaparotomy if you have it early, but relaparotomy for a late bleeding after Whipple procedure or distal pancreatectomy is something that is dangerous and that you should try to avoid. This is the last thing that you should do here. For the early bleeding, of course, this is inevitable because this is, again, some technical failure, like a bile leak after your operation. It's simply a technical failure, which you probably can fix with a reoperation. The most important thing, all of you know, is probably number one, the GDA stump. All the other locations of postoperative bleeding are not so frequently observed. However, if you have some intraluminal bleeding, we have seen that this is often at your stomach anastomosis or your duodenal anastomosis. Some patients develop some ulcers here, or you just have some mucosal bleeding. And this, of course, is something that you can fix endoscopically. The important thing regarding the bleeding is you always have a sentinel bleeding. This bleeding doesn't happen at one time. Usually this bleeding happens at 2 times. The old study from the Netherlands, and this is done for some different indication, this study, but you see the patients who had a sentinel bleeding after the episode of massive bleeding then is 78 to 100%. So this means you have to be very careful, very alert whenever you have only a little drop of blood in your drains. As you see it like here, you come to your morning round, patient is fine, patient is stable, but the drain has changed and it looks like this. You should always be aware this might be the sentinel bleeding 8, 12, 24 hours later. This patient is at a high risk to develop a massive bleeding and also a life-threatening bleeding. Whenever you have this, again, your radiologist is your best friend. You see the classical GDA stump bleeding. You can fix this by coiling or, as shown here, by stenting. Important thing is you do not do any harm to your liver artery when you put in a stent. The bad thing is you need to put some anticoagulation here. And this, of course, again, increases your risk of bleeding. Otherwise, you have a high risk of closing the stent. So this is, again, an unpleasant situation where you have to weigh between the risk of bleeding and the risk of thrombosis when you have put in a stent. We still prefer the stents. Some centers like to do more the coiling of the GDA stump, but I think the stent is at the moment the better solution to fix this. This is an example of coiling. The coil closes this GDA bleeding that has been shown in the first image. This is only possible when you again have a long stump of the GDA. And of course, you can imagine that this hepatic artery is not really pleasant for stenting because the angle you have to put the stent is not really suitable, not really working. So you need to have both possibilities, coiling or stenting, depending on the location of bleeding and of course also depending on the anatomy of your patient. When you do this, you can also, again, avoid reoperation in many patients. We had this experience with 25 patients with a late bleeding, so not an early technical bleeding, but a late bleeding. First thing is go to the CT scan and the angiography. This localizes your bleeding in almost 100% of the patients, and you know what you are talking about. And afterwards, you can do an embolization. and you can close the bleeding, or you can put in a stent, which I mentioned already, I prefer today. However, the success rate of the radiologist is very high, 95%, and you don't need a reoperation in these patients. But still, even if you manage it the best way you can, mortality for postoperative delayed bleeding might be still as high as 20%, which shows you the severity of this complication. And as you know, in most of the patients, the bleeding is not only the bleeding, but the bleeding also occurs because of a fistula that you have in the background. And this has done the erosion to your hepatic artery, to your GDA stump. And then you have to fix both the fistula and the bleeding. For the end, I want to show you this, I think, very important study, again, from the Netherlands. They have called this the Porsche trial, not because of the car, but it was just a nice name for the study. And what they did is they looked at the management of complications after pancreatic surgery all over the country in the Netherlands. And then they said, yes, every center does it a little bit differently. And they included 17 hospitals in the study. And what they said is, first, everybody can do what he is used to do. And then by randomization, we change the management of the pancreatic complications due to an algorithm that everybody has to follow, which is really fixed, which shows you what to do, and you have to use this. And during the study period, then all of these centers changed slowly due to the randomization process, and finally included 1,800 patients here. The algorithm was quite simple in the end, although it looks a little bit complicated here. They put it on a mobile phone app, and everybody could check on the app what to do, especially when you have a high CRP, when you have high leukocytes, when you have any other symptom that you do not like. And then this app gave you a standardized diagnostic and therapy. And the focus, of course, of this study was put on how to do a CT, when to do a CT scan, when to do antibiotics, and when to put drains into the patient. And this is shown here. This was on your app, on your mobile phone. You give in the data of the patient, and the app shows you, okay, do this, do this, do this. You see the groups before and after were randomized and very balanced. This large number of patients, these 1,800 patients, regarding their risk for complications, regarding their comorbidities, regarding their types of operations and everything. And what you see here is when you use your app, when you do it with a standardized algorithm, you need more CT scans and you need the CT scans earlier. So, of course, this might be a little bit expensive and you need, again, a good radiologist. And the other thing is that you have a higher rate of antibiotics that you administer for the patients, but you can also lower your reoperation rate when you use this algorithm and you do your complication management in a very standardized way. And the most important outcome of this study, I think, is this. When you use your intervention, you can lower your mortality down to 3%, although this was already very good in the Netherlands before they did this study, but it shows you using a standardized algorithm, put this as a mobile phone app or put this just in your doctor's room in your hospital, take a look, see what you should do when your patient has blood in the drain, when your patient has a high CRP level, when your patient has a high blood pressure or low blood pressure, and then the app tells you, do a CT scan today, give antibiotics today, do a CT scan again in 3 days, put in a drain now, put in a drain later. And this, I think, is very elegant because it shows you when you standardize your procedures, you can improve your outcomes. Even if your outcomes may be good already, there's always still some room for improvement, and you can save 2% more of your patients from some fatal complications after pancreatic surgery. And now, having said this, for the end, just 2 slides. This is again the failure to rescue that I started my talk with. This is also already 15 years old study, and this was done in the United States with hospitals that reported a very low mortality, medium mortality, high mortality, and very high mortality. So these were kind of some quintiles of these hospitals. And you see between these and these, the difference in morbidity was only twice, but the difference in mortality was 5 times. So this tells you the hospitals do not necessarily operate very much better. They do not necessarily have very low complications or very high complications. The important thing is the failure to rescue. If you don't recognize your complications, you don't address your complications, you have a 5 times higher mortality in the end. And this is shown here, factor 10 risk in the end between the very poor performing hospitals and the very well performing hospitals. And this can be done in every hospital if you have the infrastructure, if you have the experience. You just need to react early, recognize your complications, do your CT scans, do your drains, do your antibiotics. And this is very helpful for the patient and also for you, because you don't want to have a mortality which is 5 times higher than the next hospital in another city. And therefore, this failure to rescue is something that can be avoided and that should be avoided today for fistulas, for bleeding, for septic complications. So I hope I could tell you something about the fistulas, about the complications, risk factors, recognition, and also the management. And of course, I'm happy for your questions and the discussions. Thank you very much.
Thank you, Dr. Hackert, for this wonderful talk. Let's see if we have any questions from the audience. I myself have 2 small questions. We had before one of your colleagues from Heidelberg, Dr. Jan Schmidt. He gave us a talk, and he was talking about this technique he does in pancreatic surgery, where he inserts 2 drains, one fixed anterior to the anastomosis and one posterior to the anastomosis. One gives continuous drip of saline, and the other is like a drain. Do you have any experience with such a technique? So it's like a
We do
continuous
this.
irrigation of the anastomosis.
Yes, I know the study from Jan Schmidt. We do this from time to time at the moment for the high risk anastomosis, and we are just now starting a randomized study for this. We have just submitted the study protocol that when you have a high fistula risk score, you put these drains for continuous spilling, and this may be helpful in some way. I don't know, but the data that Jan Schmidt has published are quite convincing. Yes.
Okay, and we had some old research here at our institute before about regarding the GDA, gastroduodenal artery bleeding. Some people used to cover it in omentum, for example. Do you do this sometimes routinely, maybe?
Yes, we like to cover it with the falciform ligament. If this is available, just wrap it around the GDA stump and fix it very softly. Do not, of course, narrow the artery. And there is one study from Dresden, from Jürgen Weitz group, who have shown that the bleeding is not reduced overall, but the severity of the bleeding is reduced when you do this. So if it's available, it's very easy to do. I always prefer the falciform ligament, not the omentum, but I think this is some preference, your personal preference. Yeah.
Okay. Okay, so, let's take some questions from the audience. Please, I encourage all the audience to ask questions if they have any. Dr. Ahmed Said Sibai.
Thank you, Professor, for a wonderful lecture. I have a question in regards to the high risk type of pancreas, type D that you mentioned. Is there any prophylactic maneuvers that we can do intraoperatively that can decrease the risk of fistula, like the falciform wrap or the omental wrap that you have mentioned? And also, does it differ if we gastrostomy or a pancreatic jejunostomy? Does it differ if we perform the anastomosis with a different technique? What do you think about this?
Yes, I mean, this is a really intense debate that has been going on for the last 10 years, maybe 15 years, I think. Personally, I do not change my technique. I try to do it the same way because I think you should not change it. You do your same standard anastomosis for every pancreas. I don't like stents. Some people put in a stent there. It might be helpful if you do an external stent over your anastomosis. It has not convinced me personally. Gastrostomy or jejunostomy, there are good data that this is approximately the same fistula rate when you do the same technique in your patients. When you do always a gastrostomy, you have the same outcome as when you do always a jejunostomy. So I think It has to do something with your standardized technique and things like that. The only thing that I still like to do is giving some octreotide as a prophylaxis, but I don't really do any surgical different measures in these high-risk pancreas. And if I think it's too dangerous, I actually take out the pancreas in some patients. Just take it out completely, but not very commonly, of course.
Okay. When you take out the pancreas completely, what's the survival of these patients? Do they live well without the pancreas? Do you need, because I think here in Egypt it's not very practical to do so because it's gonna be difficult to manage that.
Yeah, I think that's an important point because, of course, they have a severe diabetes afterwards, and you should only do this when you are sure that your patient has some good insulin management afterwards, that you have an infrastructure where you can do this. As I said, not very commonly in very selected, very few patients, but you all know these situations. You put the first stitch, the pancreas starts to bleed. You do your knot, the pancreas tears. And then you have done this 3 times, 4 times, and you realize this patient will have a bad fistula nearly 100%. In these patients, I sometimes do it, but I agree with you. It is not something for every patient.
Okay. Do we have
Thank you so much, Professor. If I may, another small comment.
Sure.
What's your drain policy in these high-risk patients? Where do you prefer to place the drains if you place any?
Well, we try to place one drain at the pancreas anastomosis in the back, at the top of the pancreas, and then we put one drain under the liver. This is our regular drain placement. And as we already discussed, personally, I like to put some drains for spilling at the moment. And then you start spilling after the operation for 2 days, 3 days. Then you stop, you measure your enzyme levels, and then you see if there is a fistula or not. But of course, the drains do not prevent the fistula. They can only make it a little better, I think.
Okay. Any other questions? Dr. Sabai, do you have any other questions?
Thank you so much, Professor. Wonderful talk as usual. Thank you so much.
Thank you.
Dr. Dani Yaqub, do you have any questions?
Thank you very much, Dr. Hackert. This was a great presentations. If I might ask for unrelenting fistulas. Sorry, this is Dani Yaqub. I work in Augusta, Georgia, at Medical College of Georgia. For unrelenting pancreatic fistulas that would not close after months and months, is there any consideration of something like, especially in distal pancreatectomies or otherwise, any consideration for like radiating the pancreas? This is a very old kind of trick. I don't know if you have experience with any of that.
I personally have no experience with radiation for pancreas fistula. For lymphatic fistula, I told you yes, but not for pancreas fistula. I think if you have the situation that you mentioned, like a persisting fistula over weeks and weeks and maybe months, you have only the option of a reoperation in the end, which after 3 months or 4 months is not dangerous for the patient. But then you can consider not to take out the pancreas, but to try to do an anastomosis to the site of the fistula. This might be possible because usually this leakage site is already kind of like a chronic pancreatitis, which will never heal, but which is good to put a new loop of the small bowel on it and to do an anastomosis to this. I think that could be the best option in these really persisting fistulas over months, as you mentioned.
Okay. Any other questions? Okay, final chance to ask a question to Dr. Hackert. Okay, I think that was it. We had a great time. Hope you enjoyed as well.
Yes, thank you again for the invitation.
And looking forward to next time.
Yep. Okay. See you. Have a nice evening.
Thank you all. And as I say, a reminder, so Dr. Bishla is May 18th, 9 a.m. I will send you a reminder before.
Okay,
Thank
perfect.
you all. Thank you.
Bye-bye.
Good night. Bye-bye.